TopMedTalk.
Hello, I'm Desiree Chappell, and this is TopMedTalk. I'm here with Monty Mythen, Editor-in-Chief. Hello, Monty.
Hey, Desiree.
Right now, we have the opportunity to sit down with another special guest, Dr. Paul Grant. Dr. Grant is the co-director, one of the co-directors of the Perioperative Summit this weekend. So congratulations to you for a great summit so far.
Thank you.
He's also a hospitalist at the University of Michigan. He's the director of perioperative and consultant medicine there. So, Paul, thank you so much for sitting down with us.
My pleasure. Absolutely. Thank you for having me.
Well, it's been a fantastic meeting so far.
Yeah, congratulations.
You guys
Thank you. We've been happy so far.
Yeah, and you can see all the effort and planning that's gone into it, and I think it's turned out well. We just came out of a fascinating session just now, which we'll come to in a bit, but it's always fun to have differing opinions up on stage and debating, so we'll come back to that in just a second. Monty and I were reflecting about the update that you gave at the very beginning of the meeting, which I think is just a fantastic way to start out a meeting. It's hard and heavy with the evidence and an update with that. So, Monty, do you want to start off asking a couple questions?
Well, we already covered off in one of our teasers the paper by Gupta K. et al., BMJ, Open, December 2018, which was a meta-analysis, I think, of opioid respiratory depression risks. And
yes,
the incidence was about 0.5%, and the risk factors, if I got it right, were cardiac disease, pulmonary disease, obstructive sleep apnea, and a high dose of opioids.
Correct.
So any other big takeaways from that? I kind of thought, the OSA thing is still a bit controversial. Perhaps we're not surprised by the cardiac and pulmonary. Not very common, I thought. It was a bit surprising.
Yeah, agreed. I think it was some nice work to add to the literature, an area we still sort of struggle with, but of course with the focus on opioids right now, certainly nationally, I think maybe even beyond, we're looking at that as a risk factor, and we see a lot of it. With pulmonary risks just being, the more common risk factors we see perioperatively. So this was nice. It kind of confirmed what we knew, I think, about some of the things that would cause risks, or at least increase the risk for opioid-induced respiratory depression, the cardiac disease and pulmonary disease. But sleep apnea, I think a lot of us suspected that's a risk factor, but it's one of those things that's kind of hard to know. I think a lot of patients have it but don't know it, so it becomes a little bit challenging. In this particular meta-analysis, these patients were officially diagnosed with sleep apnea. It was pulled out as a patient risk factor and was significant, as increasing the risk for that. Diabetes, kidney disease was not found to be significant, which is maybe not as surprising. But with respect to the other factors, it was the morphine equivalent daily dosing that was also significant, but not PCA or epidural, analgesia.
So the dose of the opioids is something I think we all agree perhaps we could do something about, combined with perhaps monitoring more closely some of those other patients?
I think that was the take-home in a sense. So what do you do with this? Well, kind of knowing these risk factors, maybe these are the patients that we really need to look at in advance and say, wait a minute, we have a patient coming in, they have pulmonary disease, they have cardiac disease, they have sleep apnea, they're on a significant amount of opioids, going into surgery.
Yeah.
We need to watch this patient intraoperatively, immediately postoperatively, and then even until discharge.
Because back in the day, I mainly do critical care. Now I mainly do surgical critical care. And way back, there used to be high dependency unit requests for admissions for patients who were now on a lot of morphine. We seem to have kind of got to a point whereby we're kind of relaxed a bit more about that, and they go back to the floor and you say, oh, you want me to admit someone because they're on a high dose of morphine now? Is that... Do we need to rethink that one?
Well, I wonder if that's true, just because the incidence of opioid use has become so commonplace.
I was just to say it's like second nature.
Right. I mean, that would be, we wouldn't have enough ICU beds to kind of manage that patient population, I think. But the increased monitoring is something that most hospitals are looking at. What do we do? Continuous pulse ox monitoring is a minimum now in many places.
You can do it remotely. If I kind of jump you forward to the area where there's perhaps more ongoing controversy. I think you presented to us 3 papers, we'll put them in the show notes, about HbA1c, and that as a risk marker and perhaps a modifiable factor, and then about glycemic control.
Yes.
And where do we stand?
Yeah,
I thought I had this one sorted out.
Yeah, no, it's great, and it's interesting because I think people jumped on this potentially a little bit too soon. So I think what we're seeing now in the data is the hemoglobin A1C is probably not the most important thing to look at in terms of making sure that looks good before moving into surgery as a way to try and reduce, perioperative complications. Surgical site infection is a big one. Whereas there was some hint of data or some data that's suggestive of that, and observational data. And I think it's just something you think, well, that's a lab I can get, and I know I can move it. If it's elective surgery, I have time to move it. Let's use that. And I think, sort of the cat was out of the bag in a sense as we're sort of accumulating more data on this, because a lot of places around the country have already instituted a cutoff hemoglobin A1C before their elective surgery. I think the elective joint arthroplasty has been the big one there. Mm-hmm. But what we're seeing now is the A1C is probably not really the best marker. It seems to be maybe kind of poorly predictive, actually, of perioperative risks. What tends to be more indicative would be the actual perioperative glucose itself. So that, glycemic control in the immediate perioperative setting. What are they immediately pre-op, intra-op, and during the hospitalization, maybe for the 3 days after surgery, or maybe the entire hospitalization. But really, what are those blood sugars? And if you can control that in that short period, then you might be looking at a better way to reduce the risk of some of these complications, such as surgical site infection.
Yeah.
I mean, one of the very large observational studies which came out of Duke, I think it's a trawl, it sounds like an ugly word. Their EMR, which goes back to 1999, a huge cohort of patients, cardiac and non-cardiac patients. Now, the non-cardiac patients, if I was listening right, there was an inverse relationship. So
with the A1C.
What's that?
This was a large cohort of patients, single institution, but correct. It actually showed that a lower A1C had a higher incidence of mortality. Mortality was their only endpoint in this particular study. Tens of thousands of patients. That didn't make sense. What the author sort of thought was maybe it was these patients that received the most aggressive care because they had the ones that had terrible A1Cs. They got aggressive care in the intraoperative, immediate operative sort of setting, and maybe that's why that showed the way it did. That their mortality actually seemed like it was better, having a higher A1C in that case. Again, the A1C predicting weeks to months prior to the surgery. What this really showed when they looked at that same non-cardiac population. Non-cardiac surgery population was the glycemic control, though, was significantly worse. Mortality was higher for those who had the higher incidence of poor glycemic control.
We'll put it in the show notes, but I think it's Van Den Boom, W. et al., Diabetes Care, April 2018. We'll put the full quote in. For the cardiac patients, there was a U-shaped relationship for the glucose control.
Exactly, that was exactly, and that was very clear as the graph demonstrated. So basically showing having quite a low blood sugar level was increasing risk of mortality. Having a very high blood sugar level, same thing, high risk of mortality. So really there's that sweet spot there in the middle, the bottom of the U in that U-shaped curve
140
was really exactly in the 140 range, was really the lowest incidence of postoperative mortality and where you want to be.
Yeah. So pending further evidence from large prospective randomized controlled trials, intraoperative glycemic control, not tight glycemic control, but glycemic control remains a rational approach to this challenge.
Correct. And I would say intraoperative, maybe even a little more perioperative with respect to, the post-op day 1, 2, for example. I don't think we have an exact period, but intra-op and give or take 2 or 3 days.
What's your upper limit tolerance for...
Good question.
When do you say, ooh?
Well, because as a hospitalist, I'm seeing a lot of non-surgical patients, and there we seem to be a little more lax in some ways. You mentioned this earlier, the low glycemic patients are the highest risk, really, for immediate complications and serious complications. So I think we're really looking in that, 120 to 140, maybe even 160 range is probably the sweet spot for these patients.
Yeah. So when it starts to get sort of resident ugly, do something about it. Does that translate?
That sounds about right. Yeah. That sounds about right.
and the last one we highlighted, we're going to have to break in a second because we've got to go and do some breakout sessions.
Yes.
Was the Frailty score paper takeaway, McIsaac D. et al., was the clinical frailty scale was equivalent to the modified Fried index, which I didn't know about, but I know the clinical frailty scale. But the advantage of the CFS, as you said, it was easier and it was quicker.
Quicker to do. I think the average time was 45 seconds or something like that. Where it was over 5 minutes to do the other instrument. Both were moderate for sensitivity and specificity for predicting frailty that would lead to either death or permanent disability. But I think it just highlighted an area that we're really trying to do more of in perioperative medicine, and we really should be looking at frailty for these patients. We often focus on the cardiac cardiac risk and pulmonary risk, which are important, but I think frailty is something that we need to start really shifting some focus to.
Are you recording it routinely now, or starting to?
I'm a little bit guilty of not doing something structured formally in my assessments. I'm in my pre-op clinic at University of Michigan, but it is something that's on the list of things to sort of do in a more systematic way.
I think a lot of people would say that.
Right. It's hard. You kind of know it when you see it, you think, but until you do these things more objectively, I think that's when you're really going to see, wait a minute, this patient might seem like they're low risk from a cardiac standpoint, but they are actually frail, and we know that is a high risk for bad outcomes.
Yeah. All right, well,
we've got to wrap, but
yes.
One quick comment. Postoperative troponin rises. That was that big last session, and the wrists, etc.
Yeah.
Clear. Unclear, work in progress.
No comment.
I'm confused at a much higher level than I've ever been confused before.
Clear as mud. Yeah.
Really interesting.
It's very interesting, and that's why I love coming to the summit. I can listen to people like PJ Devereaux and like Lee Fleischer talk about these things. I mean, the data seems to be moving to a point where biomarkers probably should be implemented, at least in some patients. The higher risk patients particularly. I think the criticism has been, well, what do I do with that? If it's a high troponin, I know that's bad for the patient, but I don't know what to do with that information. But I think Dr. Devereaux says, well, I mean, we should be managing that patient very carefully, making sure they're on an aspirin, making sure they're on a statin, watch good blood pressure control. So, the managed results or trial came up. Is anticoagulation the answer? I mean, that was one trial, which did have some limitations, but seemed to show a benefit in patient with the MINS.
You do daily troponins in every patient postoperatively?
Every patient, absolutely not. Yeah. And in fact, I'm pretty much only doing it in patients who have some concerning symptoms, but that's not what MINS is. This is high-risk patients without symptoms, considering getting that troponin. And I suspect I might need to consider doing that in some of my more high-risk patients, given where I'm seeing the evidence move.
Yeah. All right. Well, Paul, thank you so much for sitting down with us. Hopefully we'll get another opportunity. We can maybe dive into frailty a little bit more and some of this other stuff. But look forward to the rest of the meeting, and thank you for all your hard work. You can see it's paid off. So
my pleasure. Thank you so much for having me. Thank
absolutely.
you. Thank you very much. Absolutely.
TopMedTalk.
Thanks for downloading TopMedTalk. Don't forget to subscribe via your podcatcher. Don't forget to check us out on social media. We're on Twitter, Facebook, LinkedIn, and YouTube. And also, don't forget, TopMedTalk is the broadcasting arm of EBPOM, Evidence-Based Perioperative Medicine. We'd love you to find out more about that. If you check out ebpom.org, you can find low prices on some of the conferences we're organising around the world. Many of them are virtual and don't even involve you leaving your own home. Check out ebpom.org now.